Good afternoon. It's Norm Buckley here. And Jason Busse will take over the screen in just a moment, but I'd just like to welcome you today to this webinar. And as you can see from the title screen, Dr. Busse is going to be reviewing the current newly updated Canadian Guideline for opioid therapy for chronic non-cancer pain. This has been released very recently, and in fact, if you're a physician and receive the CMAJ, the Canadian Medical Association Journal, in its print form, you will have received in this past week an insert also, which outlines the key messages of the guideline. Dr. Busse is a chiropractor and a clinical epidemiologist based here at Master in the National Pain Center, and was the lead on the revision and updating of this guideline. Now, if I could just ask, before we get started, if you could all please mute your microphones. We do get a fair bit of background noise from various rooms, and if you mute your microphones, then you'll be able to use the written chat feature to send questions in. But we won't get a lot of background noise on the overall webinar. Excuse me. So, Dr. Busse, as I said, led the process. He was responsible for conceiving the process of revising the guideline, brought into play Dr. Gord Guyot, from the Department of Clinical Epidemiology, who's one of the world's experts on guideline development. I think Dr. Busse can describe the process of a little more completely than I would, but I think suffice to say that we've spent the past 2 years revising this guideline, obtained a great deal of input from a number of groups, as well as a considerable amount of background research, knowledge syntheses, and prepared a pretty good evidence brief to inform the guideline panel. So I think I'm going to ask Dr. Busse to take over now. Jason, if you want to take control of the screen and begin, but thank you very much. And as I said earlier, if there are questions from the listeners online, if you can use the chat feature to send the question in, we'll try to adjudicate those. Thanks very much.
All right. Hello. Thank you very much for that kind introduction, Norm. And I'm just going to share my screen so you can see the material I have here. So I'm delighted to have the opportunity today to present on the guideline. I am very happy to take any questions that individuals may have during the presentation. There's a chat feature where you can type in any queries, and I'm going to try to keep an eye on those. I have a bit of a split screen here so that I can keep track of that, and I'll try to address them as they come up. As Norm mentioned, the purpose of today's presentation is to talk about the newly updated and released Canadian Guideline for opioid therapy in chronic non-cancer pain. And I'm going to... Oh, there we go. In terms of conflicts of interest, the guideline update was supported by grants from the Canadian Institutes of Health Research and also Health Canada, and I have no other conflicts of interest in relation to this presentation. In terms of background, I think nothing new for individuals on the call, but approximately 20% of Canadians suffer from chronic non-cancer pain, and opioids are often prescribed for management of this complaint. Disproportionately so in North America, which represents actually less than 5% of the world's population, but consumes 80% of all prescription opioids. And increasingly, as rates of non-fatal and fatal opioid overdose have continued to rise, many have questioned whether the current utilization of opioids in North America represents evidence-based practice. There are other side effects associated with opioid therapy for chronic pain. In particular, physical dependence will develop in all patients engaged in long-term opioid therapy. There was a recent systematic review which came out in Pain in 2015, which estimated the rate of addiction following prescription of opioids for chronic pain at between 8 and 12%. We've reviewed this literature ourselves, and we feel that number is a little high. The figure that we felt more comfortable with was approximately 6%. So lower than the current estimate in the systematic review, but still an event that bears consideration. There was also a large observational cohort study published in the Journal of the American Medical Association last year that tracked a large group of patients that were prescribed either opioids or a non-opioid medication for moderate to severe chronic pain, and determined that individuals prescribed an opioid were at increased risk of death compared to alternative medications. So the studies I'm putting up here are fairly new, and the increased awareness about some of the harms that can be associated with opioids is fairly new information, I would say, in general. I did mention that North America is the top consumer of prescription opioids, and it really is an issue of some debate whether America or Canada is the top prescriber. I've put up two diagrams here that appeared in a recent review in the journal Pain. The red line indicates 400 morphine equivalents, so I've put the diagrams in such a way that aligns between them. The diagram on your left is Canada, the one to the right is America. This is not all opioids that are prescribed, but it's certainly a number of them, and the top pink line is the total morphine equivalent dose per individual prescribed opioid by country. And what I want to draw your attention to is that you can see that the overall rates in America have started to dip down in the last couple of years, whereas in Canada, we continue to see an increase in overall morphine equivalent dose on a per capita basis. One of the reasons that rates of prescribing may have started to dip somewhat in the U.S. and one of their responses to their opioid issues was to task the Centers for Disease Control to create a guideline for prescribing opioids for chronic pain. This was released, as you can see, in March of last year. And the report had some things they did well, but it also had some limitations. Nonetheless, this was greeted enthusiastically by some of the colleges in Canada, and you can see here a media release from the College of Physicians and Surgeons of British Columbia, whereby they used the guideline in order to inform new standards for opioid prescribing for chronic pain. There are, however, some limitations to this guideline. Firstly, they largely restricted involvement to experts who have been critical of opioid use for chronic non-cancer pain. They had very limited involvement of patients, and when I say limited involvement, they listed a total of one patient that was engaged in the process partway through with an unclear role. They placed excessive restrictions on selection of evidence. So to give you an example of what I mean by that, when we looked at the evidence, the randomized controlled trials that exist to inform the effectiveness of opioids and the short-term harms, we found a total of 94 randomized controlled trials that we could use to inform the evidence for effectiveness and short-term harms. The CDC considered a grand total of 0 trials. They wanted a trial that followed patients for at least 1 year to be eligible. They said since no study has done that, they based their recommendations on effectiveness on expert consensus instead. They did use the grade rating system, which is a way to appraise the quality of evidence for effectiveness and harms. However, the application was a little bit unusual. As Norm mentioned, we had the benefit of Gordon Guyot as our steering committee chair, who was pivotal in developing the grade rating system, and so we were able to address that limitation in our guideline. The CDC also made what we felt were excessive use of strong recommendations in the face of low quality evidence. A strong recommendation, we feel, should only be made when you have quite high quality evidence, and that was not the case for the CDC recommendations. And finally, there were some vagueness in some of the recommendations that were made. For those that are interested in more details on this, we published a commentary in the Canadian Medical Association Journal, which came out in 2016, which elaborates further on some of these issues. Now, just to give you an example of some of the recommendations where we felt there was vagueness, this would be an example. The recommendation was to, quote, consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh the risks to the patient. Another example would be continue opioid therapy only if there is clinically meaningful improvement in both pain and function that outweighs risks to patient safety. Now, these are very reasonable statements, but they provide very little specific direction on how to make these decisions. I think all clinicians are interested in only prescribing therapy that entails more benefits than harm. But what's really required is an understanding of under what situation that condition is not likely to be met. Now, there was one recommendation the CDC guideline made that was very specific, and they advised that clinicians should avoid increasing doses of prescribed opioids to 90 milligram morphine equivalent per day or greater. But they did not provide clear guidance on how to reduce patients currently using higher doses of opioids. And we have a substantial number of them in Canada. Current estimates are anywhere from 500,000 to 1 million Canadians are prescribed long-term opioid therapy for chronic non-cancer pain. There was one cohort study which was done by Tara Nomes and Dave Yerlink and some of their colleagues, looking at a cohort in Ontario, and they concluded that for individuals prescribed opioids for chronic pain, 40% of them were receiving doses of 200 morphine equivalent per day or greater. 20% were receiving doses of 400 morphine equivalent per day or greater. So the challenge with putting out this very clear direction but not providing guidance on what to do with patient at higher doses puts people in a bit of an awkward situation. And again, this is another study that came out recently that found 30 million tablets of high-dose opioids are being dispensed in Canada annually. And this is a study that I conducted with Norm and others at the Chronic Pain Clinic here at McMaster, showing that the median morphine equivalent dose for patients prescribed opioids was 180 milligrams per day. So the challenge with adopting this recommendation is that physicians that then take this as direction to abruptly taper patients receiving higher dose opioids to much lower doses can be either withdrawal reaction, uncontrolled pain, anxiety for patients, or even loss in trust in the patient-physician relationship. And there have been some preliminary reports that some of this may have resulted in individuals that are abruptly taper, looking to seek opioids from illicit sources, and this, of course, can have fairly dramatic unintended consequences. So I think that this highlights one of the real significant challenges of putting out guidelines regarding opioids for chronic pain. We want to try to reduce the risk of harms that are associated with opioid use, but at the same time, we don't want to end up causing harm in patients that are currently using opioids and finding them to be effective for managing their chronic pain. So we have two somewhat competing agendas that we need to keep in mind. So in terms of our guideline, we were funded in March of 2015 to take on this initiative, and we began the process through a broad consultation period with clinical experts, methodologists, medical regulators, and very importantly, patients living with chronic non-cancer pain. And after a full-day meeting and looking at previous guidelines, the group decided that they would like to see the updated guideline make 24 clinical practice recommendations, and they gave us direction on what those areas should be. We determined that we would only make recommendations that we could inform with evidence, and so we undertook one or more systematic reviews for each of these recommendations. We did have a large group that was involved in helping with this process. We had a 4-member steering committee. Norm was a member of that. We had a 15-member guideline panel. These were individuals that were to vote on the final recommendations. We had a 13-member clinical expert advisory committee. These were individuals in whom we tried to acquire those who were had favorable views towards use of opioids for chronic pain. We also wanted to enlist individuals that were more critical. We also enlisted, right at the beginning of the process, 16 patient representatives in order to be part of this process throughout the development. And again, we looked to engage patients that had had a variety of experiences. We wanted to find patients that had found success with use of opioids. We wanted to find patients that had not found them to be particularly helpful. We also had one individual who had developed an addiction to opioids and since recovered. And we had one individual who was not using prescription opioids themselves, but their son had been prescribed opioids for chronic pain and unfortunately experienced a fatal overdose. So we wanted to get a wide range of opinions and impressions from both clinical experts and from patient representatives. And we did have a representative from Health Canada involved just so they could see how we were undertaking the process. In terms of managing conflict of interest, we quickly came to realize that there were two clearly defined camps in terms of use of opioids for chronic pain. We had those clinicians and patients who felt that opioids were very useful for dealing with chronic pain. The challenge was mainly to determine how best to use them. We had another camp who was quite pessimistic on their use. They felt that the side effects, the adverse events, clearly exceeded the benefit and that opioids were unlikely to have a role. So we were dealing with two issues, really. We were dealing with financial conflicts of interest and, importantly, intellectual conflicts of interest, which we felt were quite important, particularly in a contentious area. So we attempted to create our 15-member guideline panel with individuals that did not have material, financial, or intellectual conflicts of interest. We were largely successful. We had 14 out of our 15 with no financial conflicts, and we had all 15 with no material intellectual conflicts of interest. Now, I mentioned that we were going to use systematic reviews to summarize the evidence relevant to each area that we were looking to make a recommendation. But evidence alone is never enough in terms of making clinical practice recommendations. So we did provide this evidence to the guideline development groups, but we were also very concerned that we represent patient values and preferences in this process. So we acquired this information in two ways. We conducted a systematic review of all literature that had looked at patient values and preferences, and we also conducted focus group interviews with members of our patient advisory committee in order to generate a values and preference statement that was used to guide our recommendations. And what we learned was very important and quite helpful. What we learned is that patients placed a high value on small but important pain relief, and they were willing to trade rare but serious harms. they placed less value on avoiding addiction or physical dependence, and they expressed a high concern regarding the effects associated with dose reduction or cessation of opioid use. So we reviewed this information, and we placed a high value on societal considerations of minimizing the risk of rare serious adverse events such as unintentional, fatal or non-fatal overdose, but we also placed a high value on avoiding severe suffering that may accompany opioid reduction. And we decided to place a high value on patient autonomy under such circumstances. So in terms of our recommendations, we only voted on recommendations that could be informed by sufficient evidence. So if we had an area where there was not good evidence, we did not choose to rely on expert consensus. We chose not to make a recommendation. Instead, we made something separate called a clinical practice guidance statement, but it was clearly separated from our clinical practice recommendations. We required 80% consensus amongst our panel members in order to endorse any recommendation. And our recommendations could either be for or against, and importantly, they could be weak or they could be a strong recommendation. Now, a strong recommendation would indicate that all or almost all fully informed patients would choose the recommended course of action and indicate to clinicians that the recommendation was appropriate for all or almost all individuals. And these represent candidates for quality of care criteria or performance indicators. A weak recommendation, on the other hand, indicate that the majority of informed patients would choose the suggested course of action, but an appreciable minority would not. And with weak recommendations, clinicians should recognize that different choices will be appropriate for individual patients and should assist patients to arrive at decisions consistent with their individual values and preferences. So very important, we felt, to make the very clear distinction between these two types of recommendations. So what might a recommendation look like, for example? Well, for our first recommendation, we made a strong recommendation advising that when considering therapy for patients with chronic non-cancer pain, we recommend optimization of non-opioid pharmacotherapy and non-pharmacologic therapy rather than a trial of opioids. And the reason that we made this recommendation is the evidence that we acquired from a number of systematic reviews demonstrated that several non-opioid therapies achieve a similar magnitude of improvement in pain and function, but without the harms of dependence, addiction, and non-fatal overdose. Now, I mentioned that each one of our recommendations was informed by a systematic review, and sometimes many. I haven't shown them for this first recommendation because we conducted at least 8 different systematic reviews, and it gets a little busy. But this would be an example. Oh, sorry, I'm seeing a question that's come up here. Oh, and it's just disappeared from me. Do we know why North America has a higher rate of prescribing of opioids in other countries is the question I saw come up. This is an area of some active debate, and there is some uncertainty around it. But we do know that back around 25, 30 years ago, there was quite an aggressive marketing campaign by some of the manufacturers of opioids to dub pain as the 5th vital sign and to brand opioids as an effective therapy not only for palliative care or for acute pain, but also for chronic non-cancer pain. This was quite an effective campaign, and there was a large spike in sales that was seen. There was also less of an appreciation for the associated risks of opioids, and in particular, there was an extremely influential letter to the editor that appeared in the New England Journal of Medicine about 30 years ago now, that suggested the rate of addiction secondary to opioid prescription was less than 1%. this one letter to the editor has been cited over 650 times since its publication, even though the authors of the letter have come out publicly on many occasions advising that their statement was misinterpreted. They were really looking at patients being treated in an in-hospital setting. So I do think that fairly aggressive marketing is one of the reasons why you see a higher use of opioids in North America as compared to other developed countries. So, for example, with regards to the United Kingdom, Canada has 5 times the prescribing per capita of opioids than the United Kingdom does. So there has been something that has occurred here that has not occurred elsewhere. Now, I had mentioned the systematic reviews that we did, and I've put up a very busy figure here. This is called a forest plot, and each one of the lines that you'll see represents an individual randomized controlled trial that looks at the impact of add-on opioid therapy versus placebo for pain relief. And you can see this line here represents no effect, and any study on this side of the line indicates that opioids are providing more pain relief than placebo. And you'll see that in general we have studies lining up on this side. Now, we conducted a number of analyses in order to understand which of the data was particularly robust. And one thing that we did is we converted all of the measures of a particular type of outcome, whether it was pain or function or an adverse event, to a common outcome. In this case for pain, we converted every study to a 10-centimeter visual analog scale for pain. And we then looked at a subgroup effect based on the length of follow-up. So up above here, you have trials that have followed patients for less than 3 months. Down below, you have trials that have followed patients for more than 3 months. Sorry, I'm seeing Maria's asked, going back to this question is part of the reason. So are there issues in terms of access to pharmacotherapy in Canada that is perhaps not as widely available? My understanding is that even when we look at developed countries that do have publicly funded health care, UK and some of the Norwegian countries, we still see a lot more use in North America than we do elsewhere. So it may explain the difference in some cases, but there's a number of cases in which there seems to be something else that has gone on. So in this forest plot here, what we've done is we did what's called a subgroup analysis, and we found that the effect on pain relief becomes smaller the longer patients are treated with opioids. And because there's a difference, and because patients with chronic pain are treated often for long periods of time, we restricted our analysis only to those studies that followed patients for 3 months or longer. And this is the pooled effect on pain, represented by a weighted mean difference of a reduction of 0.71 centimeters on a 10-centimeter scale, which is quite precise. This information, however, for both patients and clinicians is not very helpful. What you need to know is what is an important difference in pain reduction to patients. And it's been established, at least by most of the studies we've looked at, that patients find a reduction of at least 1 centimeter on a 10-centimeter scale is an important reduction. Now, the challenge with this is the potential for misinterpretation. If you look at this average reduction and you say, well, that's less than the minimally important difference, based on that, I don't think that this is providing important relief. That's a misinterpretation. This is the average effect that patients will find. Some patients will experience more pain relief and some will experience less. And what you really need to know, if you're going to make a decision around the use of opioids, is what is the proportion of patients that are likely to achieve an important benefit. So we've attempted to provide the effect in different ways. So this is the relative risk of achieving the minimally important difference. But I think the better way of looking at this is the risk difference of achieving the MID. And what this tells us is that compared to patients that are treated with a placebo on top of their existing care, those that are provided with a prescription for opioids, 12% more of those patients will report an important reduction in pain relief, which equates to a number needed to treat of 8. So this means opioids are not going to work for everyone, and that, on average, you will typically have to prescribe them for 8 individuals to find one that will report an important benefit. Now, we also looked at publication bias. This is a funnel plot, and we expect to see an equal distribution. These are larger studies. These are smaller studies. We like to see this triangle nicely filled out. And if you look at this, you'll notice there appears to be quite an absence of studies here. What this means is that we appear to be missing trials that are less supportive of opioids, at least for smaller studies. And when we do a statistical test, we do find that there is a significant, evidence of publication bias. So what we then did is we restricted the analysis to those studies that followed patients for more than 3 months and that were at low risk of publication bias, meaning they were the larger trials up here. So when we do all these analyses, what we would end up providing to our guideline panel members is a table like this. And it would provide them with all the outcomes that our patients told us were important to them. It would provide us with the effect estimates, both as a relative measure and also as an absolute measure, and the quality of the evidence, and a summary statement to indicate the overall impact of opioids on a given outcome. And so we can see here, when compared to placebo, the addition of opioids will provide, on average, a modest improvement in pain, a modest improvement in function. There is a risk of addiction. Again, we felt it was approximately 5.5% based on the literature we looked at. There was a low risk of fatal overdose of about 1 in 1,000, but it does go up at higher doses of opioids. A similar trend with non-fatal overdose. Again, higher risk, and the risk increases at higher doses. And from a number of large population surveys conducted in both the US and Canada, we know the rate of diversion of medical opioids is about 5%. So we're looking at the totality of all this evidence. Our panel members made a weak recommendation that for patients with chronic non-cancer pain without current or past substance use disorder, and without other current psychiatric disorder who experience persistent pain despite optimized on non-opioid therapy, we suggest adding a trial of opioids rather than continuing therapy without opioids. And as I can hope was clear from that fairly busy table I put up, we made this recommendation on the recognition that on average, opioids will provide modest benefits in pain and function, but there are some adverse events that need to be considered, including some important ones, even though they are rare. Our third recommendation was that for patients with chronic non-cancer pain with an active substance use, we made a strong recommendation against use of opioids. And we did this because compared to individuals without an active substance use disorder, patients with a substance use disorder were at increased risk for addiction, non-fatal overdose, and fatal overdose. And the other thing that we realized is that in none of the trials that we found had authors enrolled patients with active substance use disorders. So these patients are systematically excluded from clinical trials. We have no reason to believe that they're going to achieve greater benefits than patients without substance use disorder, but we do know that they're increased risk of harms, including some fairly serious harms. And this is why we felt a strong recommendation was warranted based on the evidence we had. Our fourth recommendation looks at individuals with other psychiatric disorders. whose non-opioid therapy has been optimized but still experience persistent pain. And we made a weak recommendation to stabilize their psychiatric disorder before considering a trial of opioids. And again, a weak recommendation means that an appreciable minority of informed patients will choose not to follow the recommendation, but we felt the majority would. Why? Once again, compared to individuals without active mental illness, patients with mental illness and chronic pain were at higher risk for opioid addiction, non-fatal overdose, and fatal overdose. And as we saw with substance use, these patients are not enrolled in clinical trials. So they have been systematically excluded from trials that give us evidence around effectiveness. We have no reason to believe that opioids will be less effective, but we do know they're at higher risk for harms. And again, we found a similar situation in place for individuals with a history of substance use disorder. We've made a weak recommendation, meaning that an appreciable minority of patients would choose not to follow the recommendation, but we believe the majority would, again, for the same reason that they are at higher risk from the evidence we have available of both addiction, non-fatal, and fatal overdose. And there's no evidence that they achieve any greater benefit than the modest effects that I showed you in the previous table. And again, these patients are systematically excluded from clinical trials. Our sixth recommendation was again a strong recommendation, and we advised for patients with chronic non-cancer pain who are beginning opioid therapy. And I really want to stress that. This is not for legacy patients that are currently engaged in opioid therapy. These are opioid-naive patients who are beginning opioid therapy. And we made a strong recommendation to restrict the prescribed dose to under 90 milligrams morphine equivalent, rather than no upper or a higher limit on dosing. And the reason we made this recommendation was twofold. We had 8 randomized controlled trials where they explored the impact of different doses of opioids on pain and function. And in these 8 trials, they showed no difference on average. Now, that doesn't mean that there can't be individuals that might experience greater benefit, but on average, there was no clear evidence for improved benefit at higher doses. And at the same time, we had fairly clear evidence from large cohort studies demonstrating that the risk of both non-fatal and fatal overdose does increase with higher doses. So because we had no evidence for greater benefit, and we did have evidence for greater harm, we felt that for opioid-naive patients, it was reasonable to stay under 90 milligrams morphine equivalent per day. Now, we began to see an increase in risk at doses of 50 milligrams or higher. But again, because the risk increase was less, we've only made a weak recommendation to stay under 50. And again, a weak recommendation means that an appreciable minority of patients will choose to go against the recommendation. So this is a case where patient values and preferences need to come into play. They have to understand that, on average, there's no evidence of greater benefit. It doesn't mean that some patients won't experience greater benefit, but they do have to be willing to accept a higher risk if they want to go above that. If the patient accepts that risk, then it's reasonable to offer them a dose of higher than 50. Our 8th recommendation looks at patients that are currently using opioids, but they continue to experience persistent problematic pain or problematic side effects, and we've made a weak recommendation to look at rotating to other opioids rather than keeping the opioid the same. It's a weak recommendation because the evidence was of low quality. We had single-armed observational studies, but these studies did suggest that at least for some patients, they may experience a large improvement in pain and physical function. And so we felt it was reasonable to suggest that patients that are trying opioids and finding one isn't working well, that they may want to look at a different opioid before abandoning the trial. Our 9th recommendation now focuses again on patients currently using opioid therapy. And the recommendation advises that for patients currently using 90 milligrams morphine equivalents per day or more, we suggest tapering opioids to the lowest effective dose, potentially including discontinuation. Now, this is a weak recommendation, and it's a weak recommendation because we have limited evidence to support the recommendation. We have some observational data suggesting that reducing the opioid dose might reduce adverse effects, including cognitive impairment and the likelihood of overdose. But we also know some patients are likely to experience a significant increase in pain or decrease in function that persists more than 1 month after a small dose reduction. And so we've made it explicit in the remark associated with this recommendation that tapering may be paused and potentially abandoned in such patients. And I've already heard at least a few anecdotal stories that some patients are being brought down aggressively from higher dose of opioids to 90 quite quickly. And again, we're going to put a lot of effort into the education around this recommendation, conveying that this is a weak recommendation. It depends on having that discussion with your patient, and it should allow for the potential that even patients that agree to explore a taper may not be able to taper lower, to the point of 90 milligrams. That's quite reasonable. So this is a recommendation that has, in my mind, the potential for causing more problems than it solves, and we have to be very explicit about making sure that it's understood and implemented correctly. Now, our 10th recommendation advises that for patients with chronic non-cancer pain using opioids and experiencing challenges in tapering, there's evidence that a formal multidisciplinary support program can be effective in helping them. And the reason we made this recommendation is because we have moderate quality evidence that multidisciplinary support can substantially increase the likelihood of successful reduction or discontinuation of opioids. But at the same time, our clinical experts advised us that these programs are often not available, and they often have long waiting lists, and they often entail high out-of-pocket expenses. And they said this is a recommendation that is going to be extremely difficult for many providers to implement. So recognizing those resource issues, those barriers, we've made an associated remark that a very reasonable option is to look for providers in an area and to build a multidisciplinary support group, if possible, to provide this kind of support for patients that are struggling with their taper. Now, I said we tried to make 24 recommendations. I've only shown you 10. Where's the rest? Well, it turns out for the other 14, we did not have sufficient evidence in order to make a formal recommendation. But we did want to know about things like co-prescribing of sedatives, immediate versus controlled release, risk mitigation strategies, total dispensed at one time. So for these areas, we've made clinical guidance statements. So these are based on the best information provided by our clinical experts, but they're not formally graded. We had limited evidence. We couldn't make recommendations. We've provided the evidence in the guideline that does exist, but they're not formal recommendations. But I did want to talk a little bit about this idea about use of opioids based on the type of chronic pain condition, because this has become a matter of practical importance for patients that are in British Columbia. And that's because the BC College of Physicians and Surgeons has fairly recently implemented a new standard. And the standard states that long-term opioid therapy is not indicated for headaches, fibromyalgia, low back pain. And we were curious about this. So it's neither feasible nor appropriate or useful to review the evidence separately and make separate recommendations for every known non-cancer chronic pain condition. The question is, are there types of condition? Are there subgroups in which opioids are either more effective or less effective? So we turned once again to our clinical expert committee, and we said, we're going to give you a list of the kinds of conditions that have been enrolled in clinical trials, and we want you, without us giving you the results, We want you to try to cluster the conditions into similar groups, and they were unable to come up with a single approach. But we had some experts cluster them into objective versus subjective conditions. We had some cluster them into neuropathic versus nociceptive versus central sensitization. We had others that grouped them into neuropathic versus non-neuropathic. And we said, we're going to look at all these. We'll see if we can find a difference. So here again is one of these very busy forest plots, and what we've done is using the groupings provided by our experts, we've compared the effect on pain relief for the objective conditions, and so objective are down here, like rheumatoid arthritis, for example, subjective are up here. And we found no difference in pain relief between the two. We can do a formal statistical test called a test of interaction, and it is highly non-significant. So we saw no difference for a subgroup effect when we look at subjective versus objective. What about neuropathic versus nociceptive versus central sensitization? Again, you can see the pooled effects all overlap. Our test of interaction is non-significant. What about neuropathic versus non-neuropathic? Well, here we see it's not significant, but it's a little closer. The neuropathic conditions seem to be getting a little bit more pain relief. Again, the absolute difference is fairly small. It's a difference of 1.06 centimeter versus 0.78 centimeter. Test of interaction is not quite significant, but it was close. And we said, all right, what we should do then if we want to really understand. Oh, I see a quick question. Did you consider patients who are slow versus fast or ultra-fast metabolizers? And that would have been a wonderful subgroup analysis to do. Unfortunately, we can only do subgroup analyses on factors that are reported by clinical trials. And the clinical trials, the 94 clinical trials that we had available to look at, never enrolled either fast or slow metabolizers in isolation. They never reported the proportion of fast versus slow metabolizers or reported those results separately in a trial. So while that is an extremely valid hypothesis to explain differences in treatment effect, we were not able to formally explore it based on the data available to us. What I'm showing you in this table here is this is an unadjusted analysis. So this is looking at neuropathic versus non-neuropathic. We see a close to significant p-value. And this is length of follow-up. That was the other factor we found was important in terms of determining the effectiveness of opioids on pain. This is when they're added into the same model. So this is adjusted. And you can see here the significance for clinical condition becomes even less significant. We were not convinced, looking at any of these different subgroupings, that there was evidence for a subgroup effect based on clinical condition. In other words, opioids appear to be equally effective across all subgroupings of clinical conditions that our experts could come up with. So why are there standards of practice restricting use of opioids for some conditions? And here's what I think has happened. There was a fairly influential review that came out in 2016 looking at opioids for low back pain. And they found, as we did, that the effects were modest. They didn't look at the results on a 10 centimeter scale. They looked at them on a 100 millimeter scale for pain. So here you see, looking at the longer term follow-ups, you get somewhere around 8 millimeter reduction on a 100 millimeter scale. And they said they do not feel that these studies showed that the average result was greater than the minimally important difference. They defined the minimally important difference as 20 points on this 100-point scale. And so they said the effect is not likely to be clinically important. Now, what's the problem with this? I showed you on our forest plot for recommendation number 2 that it is potentially very misleading to focus on average effects. We found a similar average effect, but we went the extra step and we converted to the proportion of patients likely to achieve the minimally important benefit. This study makes, in my impression, the erroneous conclusion that every single patient will achieve this kind of result. That's not the case. Some will achieve more pain relief, some will achieve less. So I think that some individuals involved in terms of setting these standards have unfortunately taken these types of studies and used them to restrict clinical conditions, and I don't believe that's appropriate. We've tried to make this very clear in the guidelines that we've put out. Now, I mentioned that there were a number of other areas that we couldn't make recommendations on, and I don't have time to go through them all, but I wanted to talk about some of the risk mitigation strategies that are so commonly recommended in guidelines. So, for example, urine drug screening would be one. And, you know, a baseline urine drug screen could potentially be useful, or even follow-up urine drug screens. We know from observational studies that about 30% will demonstrate aberrant results, either because opioids aren't found or you find other agents such as cannabinols in the urine themselves. But what's interesting is when you look back on the evidence to support the use of urine drug screening, it's limited to a single conference abstract that has never been published in a journal. Here's the results. This is it. There's a very large study, about 180,000 patients, and they looked at those that were given urine drug testing versus those that weren't, and the outcome was opioid overdose, and they found no difference between the groups. Now, this is very low-quality evidence, but at this point, we found insufficient evidence to make a formal recommendation. This is all that we could find out there, right? So this would be an example of when we say there's some evidence, but not enough to make a formal clinical practice recommendation. What about treatment agreements? Well, again, we have only low-quality evidence which demonstrates equivocal results on opioid misuse. Now, a written treatment agreement could be useful, but we simply don't know if it affects outcomes. Here's the evidence that we have, right? We have 4 single-arm observational studies that look at the rates of opioid misuse for those that sign a treatment agreement versus those that don't. And this difference, it actually trends in favor of worse outcomes with the treatment agreement, but it's not significant. And the evidence is very low quality. So again, we don't have enough to make a formal recommendation. Tamper-resistant formulations, we're in a similar position here. They might be helpful. They do reduce the risk of at least some forms of abuse, but not the most common mode, which is simply oral ingestion. Not all payers reimburse for them. They're not approved by Health Canada at this point. They may even cause additional harms if people manage to crush them and inject them, such as cardiac valve injury, and they're more costly. So we really weren't able to make any kind of a recommendation around their use or not. Fentanyl patch exchange seems like a very reasonable idea. Turn in your old patches to the pharmacy before you come in for your next refill. And in Ontario, it's required by law. Now, it's a minimally disruptive strategy. It may reduce potential diversion, but at this point, we don't have sufficient evidence to make a recommendation on it. Naloxone co-prescribing. We do know that this is something that clinicians have considered, particularly for patients that they deem to be at high risk for overdose. However, we only have low-quality evidence that co-prescribing naloxone with opioids for patients with chronic non-cancer pain reduces adverse events. We have very good evidence that naloxone is effective for individuals that are addicted to opioids, but not so much for patients that are provided naloxone for opioids when managed with chronic pain. Here's the evidence we have. So again, for those that are interested, this is provided in the guideline. They can look up the source articles, but we have very low evidence demonstrating no difference in fatal overdose, all-cause mortality, or rates of hospitalization. Now, our experts in general felt that prescribers of opioids for chronic pain may wish to consider implementation of risk mitigation strategies because they might reduce harm. But the alternative perspective is that prescribers adopting potentially ineffective risk mitigation strategies may become less concerned about possible opioid-related harms and more willing to prescribe opioids. So there is 2 perspectives that have to be considered here. As Norm mentioned at the beginning, the guideline has appeared in the Journal of the Canadian Medical Association, but I would really encourage those that are interested to go to the MAGIC app. We've put the entire guideline in an online application in an interactive, multi-layered format. I'm not sure if I can easily activate this on my screen for you to see. Looks like maybe I can. but it's constantly being updated. And as you see here, you can quickly go to the section that you want. You know, here's recommendation number 1. If you want, you can look at the research evidence. This is comparing opioids against all sorts of alternatives that have been explored in randomized controlled trials. You can very quickly tab onto this if you want and see the evidence that's available there. You can close any section you're not looking at. Any section that is based on a weak recommendation, such as number 2, it'll actually include patient decision aids as well. So you can create PDFs for your patients to actually demonstrate to them the differences in both harms and benefits associated with the recommendation. And these things can be printed out, or they can be used at the point of care. So we've really tried to make tools here approachable in the guideline, easily usable at the point of care. We heard from a number of pain physicians that they wanted something that was easier and more facile to use. We believe that this application does make some great strides in accomplishing that, but we'd love to get feedback from individuals about how we can improve this even more. And if I go back to here again quickly, I'm almost done. This was a recent editorial which came out from the CEO of Health Quality Ontario, and this was following a study they've done that has demonstrated the rates of opioid prescribing has continued to go up, even over the last 2 to 3 years. So it appears to be increasing, even though there's been a lot of attention put on this issue. They indicated that the new Canadian Guideline should help this issue, but they do acknowledge the fact that, you know, if we're going to be recommending that individuals pursue non-opioid therapy, there needs to be efforts made to reduce barriers to accessing these types of treatments. And right now, resource issues are an important consideration. The other thing is guidelines are not self-implementing. We really need to try to work with all interested parties, including individuals on this webinar, to get this information out into practice and to help inform both patients and prescribers about the evidence we currently have. In conclusion, this was an enormous effort that occurred over a 2-year process. There was a team of over 50 people that helped. I do want to try to acknowledge most of the key members here, and I thank you very much for your attention, and certainly happy to address any other questions you may have. Thank you very much. And I'm seeing a question here. Is there a distinction in the research between patients with a mental health disorder before they develop chronic pain and those that developed a mental health disorder after or as a result of their chronic pain? No, the observational studies that we had available to us, they looked at individuals, for the most part, that presented with evidence of an active mental illness at the time of prescribing, but we don't know whether that mental illness preceded their chronic pain or whether it came about after their chronic pain had developed. We only know that at the point of prescribing, individuals with an active psychiatric disorder were at higher risk of experiencing opioid misuse, opioid addiction, or an overdose on opioids. Okay. Oh, any difference between U.S. guidelines and ours? Yes, there's quite a few differences. So I tried to highlight some of those. The U.S. guidelines, as I said, most of their recommendations are actually what we would call good practice statements. So they'll make a statement such as, only prescribe opioids if the benefits are expected to exceed the harms, which everyone would agree with. But we've taken it a step further and we've identified patient subgroups for whom the harms are likely to exceed the benefits. And in particular, those with an active or a history of substance use disorder or another active psychiatric disorder. We've also taken the step of quantifying the extent of that increase in harm as an absolute risk increase. So one thing that we did is the American guidelines, almost all of their recommendations ended up being based on largely expert consensus, because we only made recommendations where we had evidence, we're able to quantify the actual benefits or the actual harms associated with each of the recommendations. The other thing that we've done is we've been very careful about only making strong recommendations where we had sufficient evidence to do so. So the CDC guideline, out of their 12 recommendations, 11 they qualified as strong, although they're very clear that they have only low quality evidence in every case. I would also say that because of our explicit use of a fairly large group of patients throughout the process, we have much more emphasis on explicit values and preferences to guide the recommendations. So I believe that there are some important differences. I think there's some important advantages to our guideline, but I would really encourage interested parties to look at the guidelines, in particular on the MAGIC app. I think it's a really advantageous format for conveying the information. I think the availability of patient decision aids is another useful feature there, and we're always looking to improve this document. So if you see something that you think we could do a better job of, would love to get that feedback, and because it's an active online version, we can make improvements. It's not a static document. Can you briefly explain the 90 milligram rationale? Yes, absolutely. It's a great point. I'm going to quickly go back to that, which is the recommendation number 5 here. I apologize if I'm making anyone dizzy with this. So what we had was this. And here we go. Oh, I'm sorry. That's I need to go one more forward. So what we found was when we looked across all of the randomized controlled trials that explored opioids versus placebo, we found that the median dose that was prescribed to patients was just under 50 milligrams morphine equivalent per day. When we looked at the associated interquartile range, we found that even the upper range was a little bit less than 90. So the evidence coming from all the clinical trials is almost all based on doses that are 90 milligrams or less. We did have 8 randomized controlled trials that looked at within-study differences based on dose. And in those 8 trials, they did not demonstrate evidence of a difference in either pain relief or functional improvement. We have a couple of very large observational studies now that are consistently demonstrating higher risk of both non-fatal and fatal overdose as the doses of opioids increase. Now, what's interesting, if you look at the thresholds here that have been used, down below here, they tend to look at the risk at less than 20 milligrams. In some cases, the risk at 50 or higher, and then again at 100. And we've ended up on 90. When we had the discussion with the panel, we originally were looking at a recommendation of setting the threshold at 100 milligrams. And we received feedback from individuals there indicating that because the CDC recommendations had been endorsed or in some cases adopted by 2 or 3 different provinces in Canada already, they advised that it would take a lot of effort to switch from a 90 restriction to 100. And so based on that practical consideration, the panel decided to end up at a threshold of 90 milligrams in order to be concordant with the CDC recommendation, which a number of Canadian provinces had already adopted, as opposed to the 100 milligram. But the evidence from the observational studies does use the cutoffs that I have below, and in some cases there's additional cutoffs that are provided in the MAGIC app if you go to the evidence profile for this recommendation. So in brief, on average, we saw no benefit of greater benefit, but we did see risk of greater harm, and that seemed to go up quite a bit as we got close to 100. Now, there is an associated remark with recommendation number 6, and I'm wondering if I can go to that very quickly, because I think it is an important one. Sorry, one other question: is there evidence that looks at long-term opioid use and risk of harm? So I would say that we do not have randomized controlled trials that have any follow-up longer than a year. If you're going to look at risk of long-term harms, you're left to go with the observational studies. And we do have observational studies that go on for a median follow-up of close to at least 3 years. So we do know that there's some evidence out there that looks at things such as, again, typically addiction, misuse, non-fatal and fatal overdose, some limited information that looks at sleep apnea, that looks at opioid-induced hypogonadism. So there is limited evidence that looks at long-term harms from observational studies. We've tried to highlight some of that evidence where we can. I do want to go to that one recommendation, though, that focuses on this 90 milligrams. So again, this is the MAGIC app. I'm going to shrink this here so we don't need to look at all these details. That's not the one we're interested in. We're interested in this one here. And what we've got here is an associated remark. And this remark must accompany the recommendation wherever it appears. And what we've said is, although we have a strong recommendation to restrict to less than 90 milligrams per day, the remark acknowledges that some patients may gain important benefit of a dose of more than 90 milligrams. And referral to a colleague for a second opinion regarding the possibility of increasing the dose to more than 90 milligrams may therefore be warranted in some individuals. So we have not completely excluded this. We did hear from some individual patients that they had received a partial dose at amounts less than 90, and they received a better response at higher. On average, that is unlikely to occur, but there does appear to be some exceptions to that. So the remark does allow for that, but we do recommend that the consultation with a colleague occur before that decision is looked at. And I'm going to go back to the, I think there's another question that's come in. Interesting. Do these national opioid prescribing guidelines take precedence or completely replace current provincial college and physicians and surgeons opioid prescribing guidelines? It is up to every college of physician and surgeons to decide what they are going to endorse. At present, the College and Physicians and Surgeons of Nova Scotia has endorsed these guidelines. Quite recently, there was a presentation by members of our group at the annual FEMERAC meeting. That's the Federal Medical Regulators Association of Canada. All of the provincial medical regulators were there as well. So it's my understanding that they are currently having discussions about their official statements that they'll make on the guideline, but that is information that has to come directly from the colleges on an individual basis, and we've only made the presentation to them quite recently. So at present, it is only the College of Nova Scotia that I'm aware of that has formally endorsed the guidelines. And very happy to take any other questions that anybody might have. And again, if there's questions that arise after this presentation that I can help with or I can provide information, I'd be happy to do so if you send me an email or send Norm an email if my email address isn't handy. And again, we're quite interested to hear feedback. We're very keen to look at doing what we can to improve the guidelines, to make them more user-friendly, to make them more available at the point of care. And if there's any interest by anyone on the webinar in helping to disseminate the information, we'd be quite happy to talk about ways to facilitate that as well. I'm just looking. I don't see additional questions coming in right now. I'm aware that we have gone a little bit beyond the time that we had scheduled. Oh, sorry, I see one here. Excellent question. Is there strong evidence of risks of co-prescribing sedatives and opioids? So I will say this, that's an area where, again, we ended up having to make an expert guidance statement. So you'll see that when we get to co-prescribing of opioids here. So our systematic review identified 5 studies that explored the association of benzodiazepines with adverse events. 3 found they were associated with harms, and 2 did not. So we found mixed evidence here. And because it was mixed and we didn't have a clear signal, we made a clinical guidance statement here suggesting that we do not think it's advisable to combine sedatives and opioids because they'll enhance the depressive effect of each other. Now, I will say this, we would love to do what we call a living guideline. So, for example, when new evidence emerges that allows us to make a recommendation stronger, or in some cases to make a recommendation in an area where we didn't have sufficient evidence, we'd like to be able to do so. And it's interesting that this topic was brought up. There is a recent study that just came out in the journal Medical Care last week, and it's provided additional evidence on this issue. And we've already had a meeting with the steering committee to discuss whether or not we might be able to pull the panel together, update our evidence profiles, and see if there's now enough evidence for us to make a recommendation. So we're interested to see if we can do so, but at the time that we completed the guideline, we did not have sufficient evidence in this particular area to make a formal recommendation, although we certainly would have liked to. And I'm just looking again, if there's any other questions, I'm more than happy to take them. I am aware we've gone about 10 to 15 minutes over our schedule here. I'm not seeing more come up. I think out of the, oh, hold on. I do see another one here. How will the National Opioid Use Guidelines affect provincial drug programs, private insurance programs, pharmacies? The Ontario Drug Benefit Program has delisted higher strengths of long-acting opioids. Will patients see a trickle-down effect where private insurance programs follow suit? Will there be newer, stricter guidelines for opioid dispensing? Difficult for me to say. This is not something that that we've made particular recommendations around, but as anyone involved in this area knows, opioids are a topic of intense scrutiny and attention at this time. There are multiple initiatives that are going on. The delisting of the higher strength formulations happened before our guidelines were released. But there's lots of attention going on. People trying to decide whether prodrug formulations should be available with or without a prescription, or whether they should require a prescription going forward. I'm positive that pharmacists are being engaged in strategies to look at co-prescribing of sedatives. I know a number of provinces are looking to implement prescription drug monitoring programs. There's a lot of attention here. I can't say what's going to happen and what won't. What I will say is I think it's critically important that we do not overcorrect in this area. There was perhaps quite a period of time where there was, perhaps a little bit too much opioid prescribing for chronic pain. Some of the doses were getting up quite high in certain individuals. I think there's a real danger now of overcorrecting, of denying opioids to patients that are achieving benefit, or to taking patients down too aggressively from doses that are working for them, perhaps with some really serious consequences. So I think what we're certainly committed to doing is trying to ensure a balanced approach in this area. We very much want to reduce the potential risk of harms that can be associated with opioids, but at the same time, we want to be very careful about not putting patients in a worse situation. And in particular, we don't want to get to a position where we deny opioids to a patient for whom they are providing important relief. So we're committed to continuing to try to ensure that kind of balance, and very happy to work with anyone that that finds an example where perhaps that's not occurring. Okay, I think we've largely exceeded our time. What guidelines or strategies are being developed to increase access to publicly funded alternative chronic pain treatments? Excellent question. I know that the CADIT, which is the Centers for Drug Technology Assessment, they're currently conducting a number of evidence syntheses looking at the evidence to support different non-opioid approaches for chronic pain. It's something that I spend a lot of time talking about. I had the opportunity just 2 days ago to speak to a representative from the Ontario Minister of Health, and I did raise this issue that there's a real problem with restricting access to opioids and not providing any alternatives. And for too many patients, they do not have access to non-opioid alternatives that could help them, either because they're not available in their area at all, because of long wait lists, or because of out-of-pocket expenses. So it's a critical issue. It's one that I take any opportunity I have to really raise, and I've heard that there's discussions that are taking place. The meeting I spoke at on Monday was with HEAL, which is 40 different healthcare organizations that have come together to work on areas of common interest, and the issue of providing non-opioid alternatives for chronic pain was the reason I was there to speak. So I know it's on a number of people's agenda, both at the level of the provider and the level of the government, and I'm quite hopeful that we see patients living with chronic pain provided with better access to these services. I'm also aware of programs such as Project ECHO, which is being led by Ruth Dubin and Andrea Furlan, that are looking at trying to find strategies to provide access to assessment and even pain management to people living in remote areas. So it's a critical issue, and it's one that needs a lot of attention. I'm seeing one more here. Okay. I might have missed a question. I think that's the last one I'm seeing here. I am conscious of people's time, so I think we do need to wrap up. I really appreciate everyone's attention, very nice comment. Thank you. Again, nothing no project is ever perfect. I know there's areas where we can improve. We are in the process of putting out all the individual systematic reviews that form the evidence for the recommendations. Those are going to be appearing throughout the next year. Very keen to have any feedback on how we can improve things better, or where we might have slipped a little. So please provide feedback if you can. Please take a look at the Magic app and see if it meets your needs. And again, I thank everyone for their time, and have a great Canada Day weekend.